We're now going to transition to spending a little bit of time talking with the federally qualified health centers that are part of Sunflower's Food is Medicine initiative. We have 6 clinics that are participating, and for this panel, we have kind of broken them up into 2 groups, going 3 at a time. Our panel discussion will be moderated by Dr. Mariana Wetherill from OU Health Sciences Center. She's also one of the lead evaluators for Sunflower's Food is Medicine program. We're going to start by having a few set PowerPoint presentations, which each of the clinics will deliver, and then we will have a few minutes of group panel discussion. Then we will switch to our next panel and then have some time for Q&A. So I'm going to hand it over to Dr. Wetherill.
Okay, can you guys hear me now? All right. Well, I've been so privileged just to be able to be part of this project from the beginning and initial conversations with Sunflower Foundation, and I have learned so much from all the clinics as they've really put thoughtful work into the design and implementation of their food as medicine programs with many different contextual differences. And so it's been very helpful for me to see how creative you all have been in thinking through some of the challenges and your persistence. So I think to keep us on time, we're going to be starting off with CHC of Southeastern Kansas.
Hello. My name is Audrey Ricks, and I am a program manager at Community Health Center of Southeast Kansas. I am based out of Pittsburg, Kansas, in Crawford County. Community Health Center of Southeast Kansas has, at last count, 17 clinics, but we're adding new ones all the time in several different counties in Southeast Kansas and Northeast Oklahoma. And all of these are in rural areas. Our largest, I'm actually not sure about one of our new Oklahoma clinics, but in Kansas, our largest clinic is in Pittsburg, which has 20,000 people, but it gets a lot smaller from there, so we are working in rural communities. Our Food is Medicine program, we are just piloting at our Pittsburg clinic, so in our largest space. And our program is 12 weeks of food distribution, bi-weekly check-ins with a diabetic health coach, and then encouraged classes on like nutrition education, cooking classes, diabetes education, and then we encourage them, tried to require, but encourage them to meet with a dietitian in the first month of this 12-week program. So we enrolled about 30 participants. Most of them went through the whole thing. We got pre and post on them. And we enrolled them in 4 cohorts of 5 to 10 participants. So some highlights from our program in 2023 really are about like program perception and partnerships. So we had positive patient feedback from all of our participants. It was great to hear that they learned a lot from the programs. Some of this was from like our new new recipes, trying out new foods, that sort of thing, but also from our the cooking classes and nutrition education classes through SNAP-Ed. We had one participant say that she's had people over decades try to explain the nutrition label for her, to her, but she finally understood it in this class. So that was great. We also got great feedback from our providers. So we had a provider champion, Dr. Hudson. We were working from her patient panel, and we have stopped enrollment, but she's reaching out to me all the time. It's like I'm keeping a list of new patients that she gets, and she's keeping it in mind with all the patients that she's seeing. And we've heard from other providers that they are also excited about once we open this up again and expand it to other clinics. We're hearing positive feedback. We've also got some of our diabetic health coaches in some of our clinics in other counties that are trying to see if they can get their patients. They're like, can we send them to Pittsburgh for this? We're like, not yet. But so that's been great to hear positive feedback from staff and patients. Other highlights are our partnerships. So I mentioned our SNAP Ed classes that we are encouraging our participants to participate in. We tried to work with our local SNAP Ed extension agents, and there was scheduling conflicts. We're not able to host classes at our clinics and things like that, so that wasn't aligning with our cohorts. But we were able to schedule our cohorts around the online statewide SNAP Ed class schedule, and then we invited patients to come into the clinic, and we joined the Zoom as a group. So they still had that like group setting where they're able to talk to each other, but then we're joined by other people across the state that aren't necessarily a part of the program. And those classes were very successful. We would have liked to have in person so that you get the hands-on cooking experience, but K-State has done a really good job of having their online classes still get some cooking demonstration. K-State was also super willing to work with us. I think I saw Tandy on the Zoom, but Tandy Rundis she taught the classes, and she reached out to me a couple of times. It was like, what foods are you providing? Like, what sorts of things are you offering to your participants? And so even though the classes were statewide and offered to people outside of our program, she still was able to tailor them to our program. That was great. So huge highlight was our partnership with K-State. And then we had to supplement some of the food that we got from the Kansas Food Bank, and we tried to do that like at Walmart, just going in and getting the stuff, and that wasn't working. So we were able to connect with a local grocer, and he's pictured there, Tim Rhodes of Ron's Supermarket in Pittsburg, and he was super excited about it and was like, let me know what else I can do to help your program as it develops, and so he would like to be involved in future conversations. So that was an amazing partnership. So some of the challenges that we've had was a language barrier. We have a lot of our patients with diabetes are Spanish speaking, and the surveys weren't initially translated into Spanish, and then some of the class materials. So we had an issue with that. So we did not have any. We had several bilingual participants, but we didn't have anybody who didn't speak English. We were not able to offer that this first round. Our first cohort was selected by our provider, was these are patients that I think would be great. They stuck with the program, went to all the classes, all the extras we offered, had great results from it. But then as we went on, it was us trying to reach out and find more people to do it. And so we ended up with some of our tougher cases, people with less compliance and had worse results, and they didn't come to the classes that were optional. And then we found that a lot of the changes at the end, with the final A1C, we weren't seeing what we wanted, and so we were like, what's going on? And there were a lot of outside influences that we could not have foreseen in people's lives, and we're like, wow, we really need to do a better job of addressing everything instead of just being are you eating the food we're giving, that sort of thing. So looking forward, our considerations for 2024 is consider wraparound issues, recognizing the complexity of people's lives. And so expanding our check-ins to address more things, maybe involving our community health workers as well as our diabetic health coaches. But we really want to, in 2024, take some time to be intentional about redesigning our program, about including these changes, and also since the initial planning period, our clinic has expanded, and we've added a diabetic specialist provider who was not here when we were planning it, so she was not a part of our program, and that I think it would be a huge, we're missing out if we're not including her. So we'd like to take some time in 2024 to redesign the program. I think that's it.
Turn it over to Hoxie.
No. Hello? Okay. I'm Jody Dumler. I'm the Integrated Health Director at Hoxie Medical Clinic. We're out in rural northwestern Kansas. So what I wanted to say first was this grant has been definitely a huge blessing. It's helped propel and move many of the initiatives that we've been working on as a clinic as we went into being an FQ. So that's been very helpful. So our program focused on diabetic and pre-diabetic patients. We did a 12-month program. We had 16 participants, and then one did move, so we were down to 15, but the 15 that stayed did finish the program. Our program was focused on healthy lifestyle changes focused on food, so we had weekly phone calls for at least 6 months, and then we ended up having that continue as well through the rest of the program by our integrated health specialist, and she focused on goal setting as well as food and different pieces in her weekly phone calls. We had 2 meals a week provided, and we kind of had a progression. So the initial plan was 3 months of frozen meals were given to our participants, specifically through Magic Kitchen, and they were diabetic focused. And then we had 3 months of meal kits, and we partnered with a local restaurant to help us with the recipes and things. So it's provided some new ideas for our participants. And then the last 6 months, we did a voucher system to our local grocery stores. And that just kind of helped keep our patients focused on kind of help them figure out how they're going to continue these changes. And we also did a little over 6 months of fresh produce boxes that our participants received through the Wichita Food Bank. Optional were 2 education classes, and I think I would say about half of our participants engaged in the two classes that we did have. Some of our successes. Our participants and providers saw improvements. Our participants were really excited, and they did a great job of selling it and telling their friends. So we have people that want to do another program. They saw improvements in the A1Cs, but they also started telling us, hey, we're seeing changes in weight and other things. And so we've started to say, oh, we need to look at a lot of other health factors. We were able to add a registered dietitian to our team, which is something we've wanted to do for a long time. So that was really excited. So now our participants have been getting into those individual sessions as well. We've seen a bunch of community awareness around food and what we're doing, which is really exciting. I think it noted we were featured in an article, and so now we have people from other counties calling and asking, and so it's really kind of put the thought of food and the fact that the clinics are considering this as important, very kind of forefront in our Northwest Kansas area, so that's exciting. And then we have been able to build partnerships. So we worked not only with our county, Sheridan, but also 2 other counties' public health departments, and they were able to distribute some food and some classes for their participants. We partnered with K-State Extension for classes, and then, like we said, our grocery store locally. And we also were able to open a healthy options food pantry with our public health. We just didn't have a lot of that in our small town, and so we wanted to be able to make sure that if we were asking our participants to eat healthy, that they could actually have the access to the food. So we've opened that up, and so we're able to refer them and other patients as well. Future, we are really wanting to continue to have some group and interactive experiences. Our patients have really said, hey, we like getting together. We really value that. And so we definitely want to keep that kind of focus. And we also want to figure out how to keep our past participants engaged. We're kind of looking at how do we kind of do almost like an alumni thing where we can keep everybody interacting, supporting each other, and that kind of thing in the future. And they've asked for that as well. We want to continue to track more data. A lot of what we learned is that we didn't track things we wish we would have tracked. And so being able to track kind of the utilization of the phone calls and how that plays into things, different health metrics and things like that as well going forward. And we just want to continue. We've got a lot of momentum right now. Our providers are excited, our patients are excited, our community is excited. So we want to continue forward, propel with what we've got so that we're doing a lot more than just medical prescriptions. And then lastly, just staying connected and engaged with our community partners. We've established community partnerships, we've established outside of our county partnerships, and we want to continue to build on that and figure out how we can grow that and extend these services to other locations as well in our area.
Okay, so Heartland's up.
I think my slide. No worries. Hi, I'm Elizabeth Kiever. No, not at all. Hi, I'm Elizabeth Kiever. I'm the Chief Development Officer at Heartland Community Health Center, and we're a health center in Lawrence, Kansas, and we have 2 locations. We have our family medicine location, and right up the road, also on 6th Street in Lawrence, we have our pediatric clinic. So we're able to provide that wraparound comprehensive care in our community. So we've got primary care, dental, and behavioral health. And one thing that's really been a part of our organization for a very long time is a food pantry. And when we were able to do the Food as Medicine program, it allowed us to really grow the impact that our food pantry is doing. So really, when you look at our program highlights, when a participant was identified and started working with us through the program, they met one-on-one with our pantry coordinator. Her name is Karen Lowe, she's here. And those sessions, really, there's 6 core one-on-one sessions. Look at us go. All right. 6 core one-on-one sessions that Karen works with those patients. And those include that enrollment appointment. The next one is really looking at goal setting and doing those SMART goals and journaling. Then that third one-on-one, that meal planning, really focusing on the 4th one to be activity and hydration. And then looking at people's relationship with carbohydrates and healthy carbs, and then strategies for eating out. And then when we look at the classes that we did community-based classes. We did them on site at Heartland and at our community partner organizations, including Just Food, the local food bank, and Sunrise Project, a food advocacy organization in Lawrence. And that was also in partnership with K-State Research and Extension for some of the classes. But some of the classes were taught by our providers. A really good example, our mindfulness and munchies one was a class that was taught by one of our therapists on staff, and it really teaching the relationship between mindfulness and eating. So it was a really wonderful class, and all of the subjects were really keying in on the needs of our patients and what they were looking for from an education standpoint. I also just want to add that the relationships that were built in the classes were really strong. And that was something that we were seeing time and time again, was that there was a lot of bonding in these community classes, and people truly became friends and building a social network, which when you have a large percentage of the people who are experiencing poverty and obviously limiting what your entertainment options are, really powerful to have an opportunity to build community that doesn't cost money. So really, when you look at some key highlights of the program, when we look at provider engagement and referrals, we had 47 referrals from our providers, and 26 of them met with Karen and signed up for the program. But really, when we looked at what our attrition rate is, 13 really stayed strong throughout the entirety of the program. As you know, people drop off and come and go. But really, one of the things that was really key for us is our integration with our chronic care management. It is a program that we've been doing. We've got a provider who works specifically with folks who have chronic diseases between diabetes, hypertension, and that relationship was pivotal. And those that we saw working with our chronic care manager had the highest improvements of their A1Cs and really those key indicators that we were looking for from the program. So we really learned pretty quickly that integration is vital, and connecting with providers is vital to that. Halfway through our program, I know we talked a lot about this in our last one, but we were one of the organizations that was struggling with regular access to healthy food to be able to give as that supplement. And our wonderful friends from Attain, formerly known as Free From Market, joined in with us in August of 2023, and we started utilizing that system. And I know Emily is going to talk later, so I don't want to go too much into what she was working on, but really it allowed for the participants to shop from their store and get the items delivered directly to their door, and they got to pick what they want. So they got to pick culturally relevant foods. They got to pick from a variety of foods that were healthy and accessible for them. One of the things that I thought was really interesting from the Attain data that we got is when you looked at what people were purchasing, the number one item was a superfood smoothie. But when you look at the rest of the items below that were highly picked, a lot of them were cooking staples. And this really plays into some of the challenges that some of our participants and people who utilize food pantries a lot were having is access to foods to help cooking, to making cooking at home easier, tastier, more accessible, things like that. So that was something that we were seeing a lot when we were looking at what people were purchasing. So we have had 40 orders so far, and 16 people registered for that program. And also they provide one-on-one nutrition counseling with Attain. So our total patient engagement, that 23 enrolled with 13 regular attending. We had 95 appointments in 2023 and 10 classes. And then on average about 100 boxes. So we had an additional enrollment, so that's why it's 16 now, not 15. Here's a quick snapshot of data of what our overall care cupboard, our food pantries looked like over the past year. We had 9,000 visits, so that's 9,000 times our door was opened. And that served 1,562 households, making up 2,900 unique patients. That is an 80% increase from last year, which is really significant because it shows a trend that we were seeing across Lawrence where the demand for access to food over the past year has been astronomical. And that leads to one of the reasons why, especially when we started working with Attain, is because our partnership with our food bank, because of the food limitations and the increase in demand, made the volume lower and what they were able to provide our pantry, just the way our partnership was connected. So that was really remarkable to see what a significant increase that we've had and need. And we've had some really amazing patient impact. When you look at, this is just a snapshot of someone that I wanted to highlight. This is someone who not only participated in FEM, also worked with our chronic care management team, and this past year we also started a community health worker program at the clinic. And this one individual worked with all three, and that wraparound care really was able to not only address chronic disease management, access to food, but also address those social determinants of health. So patient lost over 80 pounds and really was able to have improved blood pressure and wanting to incorporate lifestyle changes and making progress on that. And that integration was pivotal for this person. So we saw the more you integrate, the better the results. And looking at kind of a summary and our goals, our key challenges were people with high social determinants of health. So one of the things that came up for us is folks experiencing homelessness who are interested in participating in the program and not being able to cook products when you have limited availability to being able to cook. So that was something that we were really struggling with. We were fortunate to start utilizing community health workers because transportation barriers came up time and time again when it came to participation. And those transportation barriers, when working with our community health workers, have been addressed by enrolling them in our transit system that we have here, that we have in Lawrence, that allows folks who have physical limitations to have door-to-door access through our paratransit route. Some of our goals: boost SNAP enrollment, improve just like Hoxie, improve some of that data utilization and measuring those outcomes in a more holistic manner. Always trying to boost patient and provider engagement. Had some feedback about wanting to do a book club and really engage further. And then we are working with our local Live Well Coalition, who got funding from Blue Cross and Blue Shield, and participate in their exercise prescription program. So exciting stuff going on.
Okay. Thank you so much. And Elizabeth, you want 5 minutes for Q&A? I'm looking at the time and what the original schedule was. How many minutes do you want?
5 to 8 minutes.
Five?
Everything's 5 to 8 minutes.
Everything's 5 to 8 minutes. Okay.
Let's don't be a little late, but this is really important stuff. You guys are not going to go hungry, I know that, so we're all good.
Okay, great. So I have just a couple of questions based on what you've brought up, and the first is really about this idea of food as medicine, almost working as a medium for being able to discover or identify other social-related health needs. And that may be upon enrollment in the program. It might be as you start building trust with that patient, and then you discover all these other things are happening. How has that discovery informed the direction you're taking with your food as medicine programs, or how you're thinking about how your programs might impact outcomes for patients based on their needs? We'd love to hear more about that.
I'll hop in. I think when we were looking at some of the broader social determinants of health, plugging in those community health workers for those transportation barriers was pretty key. I mean, one of the reasons why we wanted to go with Attain is that delivery component of it and that individual choice component. And really having that tie-in between the health workers to be able to work with a broader sense. I mean, our team, Jen, who's leading the team, became a certified community health worker because she was seeing time and time again the folks that we were working with were having those barriers, and being able to have the tools and lead a team to kind of dual connect those patients participating was really key for us. So yeah, it made a huge difference on how we shift our kind of care.
Yeah, I think for us, so we used our integrated health specialist, and so she was also checking in on mental health and isolation and all those things. And so I think just having those one-on-one conversations and getting to know the participants really made the difference. It helped us figure out, and we could hear them better. We knew what they wanted. So I mean, it's been vital. It's helped us figure out how do we get people things that they need. And I think it's opened the eyes of some of our providers as well to things that maybe they didn't realize that were barriers to their patients. So it's been very helpful just to have those conversations. And I think that one-on-one piece is really important.
Yeah. Okay. Another question that I have is just as your projects evolved and you realized, we might need a little bit more resources or programming support than what we're able to handle on our own, how have community partnerships brought resources to your food as medicine programs, more specifically, that maybe you couldn't do as well as that community partner could? And what are some take-home messages around that?
I'm always happy to talk. So, one of the things when we first started, we were doing some of our programming in our clinic, and it is just too small. So that was a big challenge, and one of the reasons why we started working with our local food bank, who has kind of a built-in hands-on kitchen area for us to be able to go there. And then when we really realized that it benefited to spread out and participate with a variety of different organizations, we started using the library. We started using Sunrise Project, and also when it comes to cooking education, a lot of times you don't have to reinvent the wheel. There's a lot of really good information out there, and our friends at K-State Research and Extension were happy to jump in and be able to say, yes, I want to participate and help out and really, when it comes to partnership and how we grow the program in the future, we're really excited about the opportunity that the partnership with LiveWell and LMH has to be able to do that exercise component too. So I don't think we would have been able to, and of course, Attain and Harvesters and Just Food, we wouldn't have been able to do the program without our key partnerships. And it just has been really pivotal for us to be able to grow and really advance the impact that it's been doing.
Yeah, I think for us, definitely partnerships were key. We had a unique experience in that we ended up our meal kits didn't go the way we expected, and so we actually were scrambling, and our local restaurant culinary owner, she decided she would make recipes for us and things, and she designed a recipe cookbook and gave us what we needed. And I mean, and that has really spurred on. It was something that we'll be able to share with future, as well as it was great for our participants to get different foods and exposure. So that was definitely something. And then just being able to partner with, like you said, we used our community wellness center for one of our classes. You know, our public health department is where we had to put our pantry. We're a small clinic. We can't do it all. And also just because our patients are so spread out, being rural and they're in different counties, it was really important to work with people in their counties in order to get them things. And so the public health were more than happy to jump on board. And so just, I think once people knew what we were doing, if they could help, they were more than happy to. And I think it just shows you the desire from the community to be a part of these things.
Okay, I have one more question since we only had 5 to 8 minutes. You had mentioned, I think, tracking some different outcomes or some different metrics, or so what do you kind of wish that you had measured that you didn't think to measure, or that we as the evaluation team didn't think to measure, and what would you want to measure moving forward with your programs to better communicate the impact and the value?
Yeah, so for us, I mean, we could kind of retro some of it, but, we didn't look at hypertension rates. We didn't look at, BMI. We really didn't track engagement well in terms of making sure we knew if they ate all of the meals, if they actually answered the phone call and talked with our specialists. And I mean, we sort of tracked it, but it wasn't as organized. And so in the future, we want to know, does it make a big difference if the participant is doing the weekly phone calls versus somebody that only maybe actually checks in once a month? And, just so we know that we're allocating our resources well. So I think things like that for us.
Okay.
Yeah, I think a big thing that she mentioned was how much of the food they are eating was not we were did you eat the food? And they were like, yeah, but it would have been nice to be okay, how much of the food did you eat? And talking a little bit more about was it enough? And did you try the recipes? Would it have been better if there were more recipes? And so some of this we got from some of the we asked most of the participants casually, in conversation, that stuff came up, but it wasn't part of the survey and it wasn't tracked. And so I think that would be really helpful.
I think real quickly for us, just, we have siloed data points. We've got, a food pantry management system. We have our EHR, and then working with one of our goals is for that data integration is expanding the ability of Azara and being able to track some of those key performance indicators that we're looking for with our patients to be able to monitor that progress a little bit better. So that's, silo data is a little bit of a challenge. And some of the things that we were collecting and looking at not going into our EHR and things like that. So just really streamlining that collection and analytics.
Okay, all right. I think we're going to do a little shuffle here now, transition. Thank you so much.
Thanks again to the 3 clinics that presented. We're going to invite the other 3 clinics up now so you can make your way to the front of the room.